Good morning. It's a pleasure to join you all from our institution today.
Well, it's good
And
afternoon to you, isn't it?
yeah, it's afternoon 12:50 for us. Now I have with me Dr. Vishnu, who is my senior fellow, and Sister Ivarani, who is the scrub nurse. Dr. Srija Pavitran is the imaging person, and we are showing a new device called as HeartX device. After the initial PowerPoint presentation, I'll show the device, and then move further. Uh,
Um, Good morning. This is our case is a 30-year-old lady who had the ASD detected during her pregnancy. Her daughter also has an ASD which was device closed. Clinical examination, she is having a normal S1, wide split S2 and a 3 by 6 ejection systolic murmur. And this is a chest X-ray which is showing cardiac thoracic ratio of 50% and there is pulmonary plethora. Here is the ECG which shows a sinus rhythm with normal PR interval, normal QRS axis, and there is an RSR pattern in V1. Here, these are the thoracic images, echo images, where we can see that there is RARV dilatation, and then there is a secondum ASD. And now coming to the transesophageal echo, in the 0 degree, we can see that there is a defect, and the septum primum is slightly deviated to the left. In the 66 degree also, we can see that the septum primum deviation to the left is well seen in the image. This is a 90-degree bicaval view in which we can see the SVC and IVC, and the primum septum is that is the ASD, and the primum septum is slightly deviated to the left. In the when we are rotating the probe slightly to the aorta, the deviation of the septum to the left becomes very clear. In this color compare image, we can see that there is an ASD which is shunting left to right, and the septal deviation is also very prominent. This is called the malaligned atrial septum or the spiraling atrial septum. So final dimensions are it's a 19 millimeter ASD which is longitudinally oval and with a spiraling septum with malalignment of primum septum and secundum. RARV volume overload is there with mild TR and no significant PAH.
Alka, can you go back and run that PowerPoint 2 slides back when the movie of the image was seen, the transesophageal? Uh, Shaq, this is just the. Can you run both the images? Yeah, here we can appreciate, Shaq, that there is a mild malalignment of the septum. The septum primum, which is coming from the inferior vena cava area, is slightly deviated more towards the left atrium, more closer to the probe, whereas the limbus, which represents the septum secundum, is slightly more towards the right atrium. Some amount of offsetting, some mild malalignment. So the device that we are going to be showing today, this is the first time I'm using this and I'm seeing this. This is called HeartX device. This was like conceptualized by Dr. Joseph Vetakatil. I will show the device first. The device has got. Can you come?
So, Shiva, just to be clear, you haven't used the device before.
No, this is the first time I'm using it.
Okay.
We
I
just
just
got
wanted to be clear.
we just got the regulatory approval, and it's a very new device, Shack. It has not been used anywhere in India. I heard that
Okay.
Dr. Tin from Vietnam had used on about 4 or 5 patients.
I'm just slightly worried that you're a bit further away from the table. So if you drop it, then what?
I'm securely holding. Okay, I will tell you the features of this device. Number one is the screw end is a little longer. So this makes it easier to grasp if there is a possibility of embolization. Number two, it has got equal left atrium and right atrium disc, more like some of these cribriform devices and all. Then number three, it has got differential waist. So if I spread it out, we can appreciate that what is closer to my finger that is closing the screw, I will just separate it out. So there is a waist that runs 2 or 3 steps. So there is a larger waist, then there is an intermediate waist, and there is a smaller waist. So for example, this particular product can be used for devices that can be, this is, it can be used for a 24. It can be used for a 22. Similarly, the device that I have kept here is one that can go for 14, 16, and 18. Now, having said that, these are the three differences. Number one is left atrial and right atrial discs are similar. Number two is the screw is longer. And number three, it has got differential waist. And it is supposed to be a little slimmer. So the waist distance is just 3 to 4 millimeter. Now, since I'm handling the device for the first time, I'm appreciating that the device is a little softer. It's quite soft compared to any other nitinol products that we have used. But whenever I create a concavity on the left atrial disc, the two discs separate out. And this separation is quite consistent. Each time I press the two edges, it reforms. But if for some reason, if I get the left atrial disc little concave, that means suppose if I have to pull the device, and if I get it concave, the device has got this memory. It opens out. I was shown one of the picture that was from Vietnam, a fluoroscopic image on an LAO projection where the two discs were slightly separated. And now I can understand why it is so. If the left atrial disc becomes concave, this becomes slightly separated. But if it is flat, the device regains its memory. So I'm thinking that if after deployment, if the device gets this profile, I probably might push the cable a little bit and see what happens. So let's see how the device behaves in real life.
So whilst you're doing that, Shiva, one obvious question is if in the defect that you're closing, the waste, you get the wrong waste, if you like, in the defect, would that, so the bigger waste, but you needed the smaller one, would that stretch the device too much?
Possible, Shaq. Actually, see, the thing is, I am not precisely able to understand also. The reason being, see, the waist is arranged in such a way that the right atrial part is having the largest waist. I'm now holding the right atrial part. I'll make it little concave so that it loses its memory. Now, I'm holding the right atrial part. The right atrial part has got the largest size and the left atrial part has got the smallest size. I feel that probably the device will get remodeled into the heart irrespective of whatever be the size of the device. And I think this differential waist really does not, I think it is not going to be clinically relevant. But one thing is that the number of devices are very less. The total, because it is covering three sizes, the total number of devices starting from say 10 millimeter to 40 millimeter, there are only 8 devices. So that makes the inventory easier. Now, I have to see how it behaves within the heart.
First things first, start with the live.
Okay. And so for this defect, are you going to balloon size or just going to rely on the
No, see, basically we got a size of around 18 to 19 millimeter by transesophageal echocardiogram that was shown a short while ago. This was recorded yesterday. Now I will show you the, can you run the balloon sizing? Because we normally don't balloon size at all. However, in this particular patient, we decided to balloon size because this is the first time that we are using. I'm getting almost around the same 19 millimeter. I didn't use much of pressure at all. I just inflated. The moment a very subtle waist appeared, immediately I stopped it. So it was not too much stretched. Here also I'm getting close to 19 millimeter. So the device that I'm choosing is the one that matches for 20, 22, 24, all the three. The other disc is 14, 16 and 18. Since I am getting 19, I am not inclined to use the one that is supposed to go for 18. About the two devices, this device has got a diameter, a total disc diameter of 30 millimeters. I'll show you. It's a 30 millimeter disc. And this one is 40 millimeter. The one that I'm planning to use is 40 millimeter. So
okay. Warrican's got a question for you.
Yeah.
Thanks, Shaq. Shiva.
Hi, Warrican. Good morning.
Hi, Shiva. Good morning and good morning for your team. Just a quick asking about, because it's very challenging anatomy. in terms of the malaligned septum, and also there's a separation between septum primum and secundum. So my gut feeling is when you deploy the device, it looks likely that the disc on the left and the right side going to flare. So I'm not sure whether you are considering of using 3D imaging to show us on that or not. So that would be great if you can. Also, second thing, it looks as if it's a little bit more flexible on this device, so maybe it may conform better to this anatomy. I'm looking forward to see that. Thanks.
Yeah, yeah, sure, Varakan. I'm also new to this device, and actually
Yes.
this particular product still has not got its own delivery system and its own delivery cable. So I'm using an Amplatzer cable as of now. I'm loading it on a 10 French short introducer sheath and pushing it through a 12 French Cook Mullin sheath. The probably I think the product, they may get a dedicated delivery system in future. As of today, we are having an Amplatzer cable.
Let me just ask Bushra on the echo appearance. Bushra, spiral septum, malaligned septum that you saw. Any worries at all?
So a 3D would have been really helpful here. I would have liked that, because what it looks like is that the primum septum is attaching anterior and superiorly on the septum just from the 2D images.
Shiva, if you just stop there for a second.
Yeah, Shaq, actually, I
Really?
want to see how the device behaves. So okay, Fluorostore
That's
this.
what we wanted to see as well, but that was too quick.
Can you show the echo once? Yeah, Bushra, I will tell you the reason why we decided not to put a transesophageal probe today. The septum was very thin. Yesterday, actually, I was doing a 3D transesophageal in the outpatient clinic. I could, the whole septum, the primum septum was so thin that the 3D imaging was extremely suboptimal. And so, and moreover, today we have another close to about 9 patients lined up for the day-long transmission. So I thought I will save on a transesophageal echo and try to make it faster. Dr. Srija is showing now the echocardiographic image. I'm going to do a limited biggle now.
Just Shiva, just hold on for a second. There's a question. Yeah, go ahead.
Yes, I'm Amr from Cairo, Egypt. So the obvious advantage of this device is that it has two waists, so can it adapt to many sizes. So how do you choose which waist you will center the device?
Yeah.
If you center it to the left side waist, so how do you recenter it to the right side? If you center it to the right side from the start, so you can pull the device to jump to the left side waist, but how do you reverse it?
Very important technical question, Shiva.
But-
That's what I was alluding to.
I don't think we have any control over which waist I am catching, which waist I am deploying. It's a spiraling septum. So the septum primum is in one side and secundum is on the other side. So I'm just looking at whether the septum primum falls into one of the waist and secundum falls into one of the waist and grips the device. I really feel that this particular concept of pulling it towards the right atrium or pushing it towards the left atrium and trying to get the device grasped onto one particular waist, I really don't think all these things will be possible.
So you mean because this is spiral septum, that one septum primum would center itself in one waist and the secundum in the other waist?
Somewhere.
In a spiral fashion along the waist of the device also?
Somewhere like that. Yeah, I think we probably should not read too much of science into this differential waist. It is a way of reducing the number of devices in the inventory. That's it.
Also, Shiva, the way you deployed it, it's going to be very difficult to have exact positioning of whichever waist you wanted.
Yeah,
Is that correct?
I think so, Shaq. I don't think in this device there is we can very plan it in such a way that I will have only an 18mm disc that is engaging.
Yeah.
We know that the nitinol's property is that the left atrial disc never fully opens till the part of the right atrium itself comes, right atrial disc itself is open, because it's still constrained.
Yeah.
As long as the waist is constrained, the LA disc is more like a ball. It's not like a disc. So that
Okay.
concept of like catching the distal waist, mid waist, proximal waist, it doesn't make real sense for me. Srija is showing good pictures that it has caught in almost all the places. It's just a simple thoracic echocardiogram. Sorry to Bushra that she is not being given the opportunity to comment on a transesophageal. The septum was too thin that the pictures on 3D was very suboptimal, and I'll try to see one left atrial LAO view to see what is the amount of bulkiness of this device. Can we go to the LAO? And I want it quite magnified when I go to LAO. Yeah, go to LAO. Yeah. Make the device come in profile. This is a Trevisio cable that I'm using. As I told, there is no dedicated device, there is no dedicated sheath as of now. That's enough. No need for cranial. Just go LAO. More and more LAO. Make the. This is what I was mentioning. If the left atrial disc becomes concave, the device separates out. Go further LAO. Go further LAO. Further.
So here's a stupid question, Shiva. Which waist is in which defect?
I will show that. I will now show that with a contrast angiogram, with the injection through my sheath, and I will try to profile the septum primum below and the septum secundum above. Go to cranial now. Retain this position, but go to cranial.
Thanks, man. Excuse me.
Yes.
I have one comment. Very nice presentation, actually, but the point is spiral septum means that the posterior and leftward deviation of the septum premium into the left atrium. That is why the usual devices will be improvised if we are closing spiral septum. This device, because it has two waists, one is compressing the premium and the other one is compressing the secondum septum. That is why it may be not improvised.
Yeah, I was telling her to hold the breath in inspiration so that the diaphragm comes down. Breathe normally. Okay, now show me that first frame when the septum was filling. Enough. Just phrase it. Yeah, that's enough. Okay. No. That's what I want. Enough. See, if I have to look at the caudal part, the inferior part, the inferior part of the septum is getting engaged in the larger waist, which is closer to the right atrium. Okay, so I am the septum primum, which is actually deviated towards the left. I have now caught it with my larger waist. Superior part, I don't have a very clear. Go back. Just go frame back.
Shiva.
Yes.
I'm going to be pretty stupid now, but just looking at the discs, looking at the TOE appearance, the two discs seem to be quite a distance apart for that thin septum.
Go next.
Am I being stupid?
But let us see on the transthoracic echo, Shaq. It doesn't look very bad. I'll show you now a transthoracic echo. I will also, in the meantime, show this device.
Shaq, can I ask a couple of questions to Shiva?
Hi, Bharat.
Go ahead, Bharat.
One question here.
Shiva, great demonstration. I have two questions for you. One is the separation between the left and the right atrial disc, as Shaq pointed out. Does it concern you from point of view of thrombus formation in the space between the disc and the septum before it endothelializes? That is question number one. And question number two is, if you look at the left atrial disc with that concave formation, by chance, if you have to withdraw this device for whatever reasons, how confident you are that a concave disc will come inside the delivery sheath?
Oh, okay. The second part of the question is easy for me to answer, Bharat. It's very soft. It's compared to many other devices. This is very soft. It's somewhere intermediate between an ADO2's thickness and a regular ambulance septal occluder's thickness. So retrievability probably is not an issue. And number two, even after you release, if you have to retrieve, the screw is quite long, that you'll be able to catch it. That's the second part. The first part, is it more looking separated? True, I'm making it look very separated by making the LA disc really concave. And there is quite a good amount of separation. But this is, I'm telling you, this is in vitro. In true body, it may be little lesser. See, now I can make it fully flat.
Yeah,
So,
but you're making it fully flat with your left hand, but on X-ray.
Correct. But now I will show live echocardiogram. Go back to echocardiogram now. See, now look at this.
Hello.
Yes.
It's Juan Granada here. Is there a possibility you're putting too much tension in the attachment cable if you relax? I mean, if you push the cable forward, the device is going to compress and we're going to have a better idea where the device is?
I told that I'm using a Trevisio cable. There is no tension at all. It's very...
Well, all right, the tension of the system, I mean.
Tension, as I mentioned, it is
what you did actually outside with the catheter.
He used his left hand, didn't he,
I
to
know,
squeeze it?
right there.
Yeah. Now, if you look at the thoracic echo images, it doesn't look so bulky as what we might anticipate. It's actually looking more, if without any like prior information, I will pass it off like usual AST device. This is the apical 4-chamber view. Can you get a parasternal short axis also? Show the aortic flaring. Yeah.
There's another question I can't see in the dark.
Yeah, hello. This is Apostolo Zikas.
Oh, yeah.
This looks like an oversized Amplature device, basically. It has a longer waist. Looks more like a muscular VSD closure device. I don't understand what is the need of this waist. Just can you explain to us what is the advantage?
I am equally as informed as you because this is the first time I'm using this device and seeing this device. As I mentioned to you, the proposer of this device has mentioned that since there is a differential waist that can go for 3 diameters, 14, 16 and 18, a single device probably will be enough for covering a 14 to 18 millimeter defects. So thereby making the inventory little less, and in this process he is also trying to make the screw end a little longer, and probably tries to avoid a difference between the LA disc and RA disc by making it more similar. I should be given another 1 to 2 years of experience with this particular product to comment more and more about this. This is the first time I saw this device about 4 days ago, and we are using this today.
So that left atrial disc is protruding quite a lot into the left atrium, isn't it? Can I just make a comment? I mean, we're discussing what this device is all about. It's specifically, from as I understand it, it's to do with this offset septum or malaligned septum. And the problem that we have in our current devices is that you are trying to splay a device from the left to the right side and negotiate a large ridge, typically the septum secundum, and then it's splayed further because the attachment, usually superior anterior, of the primum is then placed more into the left atrium. So the disc on the left side is then splaying right across with the waist to the right side. So you get this big splay and you end up with 2 problems. The first is the device may embolize, might milk itself out because it's become cotton reeled, the waist has, or the disc then leaves a gap and you get a residual leak, but both of which are really difficult to sort out one way or the other. And I think the point of this device, if it's specifically for this offset septum, is to create a second layer within the waist area to cause it, to stop it from basically milking itself out, but at the same time fill the whole hole. So you essentially oversize, which is what we'd like to do with our devices normally, but we can't because they will definitely cotton reel out if we did that.
Okay, Shiva, we've got 2 minutes or so.
Yeah, I think I see basically Shaq, the apical 4-chamber view that Srija was showing me was looking quite good. Srija, can you get me one subxiphoid short axis also? Yeah, this is just magnify that. Yeah, this also looks decent for me. Put a color, Srija. It looks good. The superior vena cava color is seen. The IVC color blue is seen. The device is closed. The defect is closed now. The device profile is looking almost similar to any other device profile.
Shiva, sorry for asking. To me, from Frankfurt, I'm not quite sure about IBC rim. Is that okay?
IV serum is caught. So can you color the
Looks
color
as if
the
there's a leak, tiny leak, or
No,
I'm
no.
not sure the red color is coming from.
no,
Copper.
the inferior vena cava
Just to
color
make
is
sure.
going into the LA disc and just turning around.
There's no
Can I?
I will release it so that you will see the same
Just-
pictures.
Is that host?
Thomas.
Oh, not Thomas.
Thomas,
Sorry.
you got up. Hi.
AP.
Just one question before you release. In the standard ASD, you would do a wiggle maneuver, and if you pushed on the device, will you then get rid of the concavity? Just pushing on the sheath
Okay.
against the right atrial disc, would that be an option?
Okay, I will try it, but being a Trevisio cable, I'm not able to
doesn't.
play. I'm not able to play much with the cable because
Trevisio doesn't allow it.
Yeah, the Trevisio does not allow it.
Very quickly, we're way behind. Mai, you had the microphone up. Very quick, brief.
Yes, go ahead, Mai. Let's get
Press
another
again.
echocardiogram.
Can't hear you, Mai. No. Try again.
Show the echo big.
Can't hear.
Is Mai virtually attending this meeting or she is physically present there?
No, she's here, but
Okay.
microphone's not functioning.
Okay.
In the meantime, Raphael, I think, is that?
Yeah.
Oh,
Now it's
Hello?
functioning here.
Yes, can you hear me now?
Hello.
Yeah, Mai, I'm able to hear you.
Can I?
Hi, Shiva, nice case. I'm a little bit confused about the device and the left atrial disc, which is playing too much to the left atrium. Might it be coat on the pulmonary venous ridge? Because this is sometimes we see when the unplugs are just is played so far apart, the two discs from each other. What do you think?
Mai, when I look at from a close quarter, it looks very sleek and
Because
it looks
from
good.
the fourth chamber here, you can see that the upper part of the disc, the upper edge of the disc might be coated in the left atrial, the pulmonary venous ridge.
Oh, no, okay. Pulmonary veins, you show the color. That's the right lower pulmonary vein. You are able to see there? It's far away. It's in another plane. This device is more anterior. Can you see Mai?
Okay.
It's that. Well, it's not.
Yeah,
in the,
I can see it now, but it kind of looks bulky. I think you need more. I mean, I don't know.
Shiva,
I can't see the.
yeah, so that's a good view there.
Yeah,
But
that's
show us
better.
on fluoroscopy, that LAO view that you showed
I will now
before.
show it. I'll just get
Can
one
we see the LAO
subxifoid and
after
then.
release? Shiva, can we see the LAO after release?
I will show you now. I will show you now.
Okay.
I'm just getting the subxifoid short axis. We can magnify on this. Yeah. Okay, color now.
Then we need to move from.
Yeah. It looks good. Okay, now can you go to that LAO view and show the device on profile? Go the same LAO. Yeah. This is more or less the same sort of image that I also saw when some of the images that were done in Vietnam, Ho Chi Minh City, were shared with me.
So the X-ray shows a bigger profile than the echo, but if you say it's flat then.
Yeah. So.
All right, Shiva, thank you very much. We're way behind. So excellent case, excellent demonstration. Welcome to your team.
Thank you very much.
Get a chance.